Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today's topic is diabetes and hypoglycemics. We will talk about insulin as well as oral hypoglycemics. So, the table of contents. Let's begin outside of the bottle. We'll do pancreas and beta cells. We'll move into the bottle's widest portion, which is the diabetes overview and the two types of diabetes, mellitus. Then we'll dive in a little deeper, insulin overview, and then blood glucose and HbA1c levels, as well as diving even deeper into insulin formulations, and of course the bottleneck area being the oral hypoglycemics, and then of course a treatment modality of type 2 patients, and a little short note on diabetic complication summary. We will summarize all the drugs that we discuss and display our references. So like we said in our last lecture, we've introduced this alert screen here. During the lecture, you want to keep an eye out for these terminologies: insulin, glucagon, the glutes, amylin, sulfonylureas, metformin, HbA1c percentage levels, as well as hypoglycemia as a terminology, and NPH insulin. Here we go. So the endocrine pancreas. Now the reason why it's called endocrine is because now we're starting our endocrine series, and pancreas releases hormones. And before we begin this whole summary, this introduction summary, I want to bring your attention to anabolism. Anabolism is an act of promotion of growth. So there's two, right? There's catabolism and then there's anabolism. Kata is to break down, ana is to increase. So when insulin promotes glycogen and proteins, insulin becomes an anabolic hormone. Fair enough? It promotes something. Therefore, insulin is an anabolic hormone of pancreas. Perfect. Now, what does it promote? Well, glycogen. What is glycogen? Glycogen is when glucose is stored. So unused glucose in a modulation of stores, that's glycogen. So insulin promotes the storage of glucose into glycogen. Fair enough? Perfect. So here we go. Pancreas holds 1 million islets, so cells, of Langerhans. They're interspersed in the glands. The glands will secrete hormones. So these islets of Langerhans hold 5 types of cells. They produce hormones: alpha, beta, delta, epsilon, A, B, D, E. Where's the C, you may ask? It's in C peptides. Okay, so just remember A, B, C, D, E. So what is alpha? Alpha is glucagon. Islets cells of Langerhans in the pancreas produces glucagon with their alpha cells. Glucagon is technically the glucose that will be used in order to use energy. However, beta cells produces insulin, the exact opposite. Insulin, amylin, and C peptides, which is 75% of the islets of Langerhans cells. Insulin is produced with beta cells. It prevents the usage of glucose into the bloodstream. Amylin and C peptides also do the same thing. And delta is somatostatin, 3 to 5%, so negligible, and epsilon produces ghrelin, less than 1%, although we'll talk about all of them in the next section here. General functions of these hormones, generally speaking, it's not the only function, it's generally. Insulin causes storage and anabolism of glycogen. So we just talked about that. Hopefully that's still fresh. Amylin, it modulates insulin and glucagon secretion, balances the appetite, and gastric emptying. Essentially, amylin balances the glucagon and insulin release, storage, and use. And it has a function of gastric emptying. Basically, it either slows the gastric emptying or it fastens it. Now, gastric emptying means anything that you eat, for example, you had a smoothie with sugar in it, and the intestines will end up absorbing that sugar. So what does sugar need to do first? It needs to leave the stomach. Amylin does exactly that. It either prevents the sugar from leaving the stomach by delaying gastric emptying or by fastening gastric emptying and letting the sugar go into the intestine to be absorbed. Therefore, it balances appetite. Okay. Glucagon. Glucagon is a hyperglycemic factor which works to move glycogen storages. So any glycogen storage that needs to be used as glucose, it moves out of storage. Glucagon breaks the storage of glycogen and it causes hyperglycemia, which is increase in blood sugar levels. Somatostatins, they inhibit secretions, just general secretions. So for example, if we are inhibiting the secretion of insulin, somatostatin will inhibit insulin secretion, glucagon secretion, and so on and forth. Now ghrelin. Ghrelin is less than 1% in the islet cells of Langerhans. However, its function is to increase pituitary growth hormone release. So not of significance in this chapter. But the significance of insulin, normally it regulates glucose hemostasis, right? Homeostasis. It regulates how glucose is used and stored. So we're talking about two words, glucagon versus glycogen. And insulin balances that. But pathologically, in diabetes, there's either a relative or an obsolete absence of insulin, leading to increase in blood sugar levels, called hyperglycemia. So technically, if I remove insulin out of this equation, sugar cannot move to glycogen and it will remain as usable sugar. That would make increase in blood sugar levels. Fair enough? So that would make insulin a hypoglycemic hormone. So I'm glad that's clear now. So for example, if I were to clear the screen and just kind of write two things here for us, that glucagon is a hyperglycemic and insulin is a hypoglycemic. And normally there is a balance between these two. But in diabetes, insulin disappears. Either it becomes absent or its use becomes limited, and therefore all that's left is hyperglycemia. When that is, there's consequences to face. And those consequences are retinopathy, nephropathy, neuropathy, and cardiovascular pathology. And this is called the diabetic complications, and it will be discussed last slide. Perfect? Great. Moving on. Let's introduce diabetes mellitus, a group of syndrome with characteristics increasing in blood glucose levels attributed to relative and absolute deficiency of insulin, state of hyperglycemia, that is diabetes mellitus. The American Diabetes Association, ADA, not American Dental Association, is the American Diabetic Association. It classifies diabetes into 4 types. There's type 1, type 2, diabetes mellitus, gestational diabetes, and then idiopathic, which is just other causes that causes diabetes. Type 1 diabetes is known as insulin dependent. Basically, essentially, there is no insulin at all. That is insulin dependent. Type 2, the more famous kind, is non-insulin dependent, which means insulin is present, but it's useless. Okay, we'll talk about these in the next few slides in detail. Gestational diabetes is when carbohydrate intolerance occurs during pregnancy. Just pregnancy. Uncontrolled state that leads to fetal macrosomia. That's when the baby gets really, really big. and shoulder dystocia. Neonatal hypoglycemia is reported. That is one research that we found. And treated with diet, exercise, insulin, glyburide, which is an oral hypoglycemic, and or metformin, which is also an oral hypoglycemic. We'll talk about these as well. But gestational can be treated. And in the idiopathic is just other causes. So now attention to this diagram here. In a pregnant woman, when there's high blood glucose levels in the mother, it brings extra glucose to the baby. Fair enough? Which causes the baby to put on extra weight, causing fetal macrosomia and shoulder dystocia. Perfect. Let's move on to type 1 insulin dependent, where there is a lack of insulin. Right? There's no insulin. General information, etiology, and treatment is how we'll go today for the classifications. Children and youth are victims of this. Absence of insulin due to B cell destruction. So here we found out that the B cells in the pancreas are dead. Therefore, they cannot produce insulin. It can be an autoimmune mediated reaction that is probably triggered by a virus or a toxin and other causes as well, but essentially B cells are dead. Without B cells, pancreas does not respond to glucose at all, which means normally when there's increase in glucose in the blood, that leads pancreas to increase insulin production from B cells. So if this is dead, glucose just keeps increasing. And there are very peculiar symptoms: polydipsia, polyuria, polyphagia. These are basically a high number of sweating, urination, thirst, hunger. These are the qualifications of these consequences. And then weight loss is seen in these patients. Life-threatening ketoacidosis and hyperglycemia are also consequences. Life-threatening ketoacidosis and hyperglycemia. What is ketoacidosis? Basically, what our body does is it tries to get rid of the glucose, but the kidney fails to do so. And ultimately, the blood becomes acidic and ketone bodies are released. Ketone bodies are life-threatening. They're radicals. They end up hurting the direct composition of DNA. It can only be treated with exogenously administered insulin only. So this is where the treatment of insulin comes into play. Type 1. Etiology? Well, it's normally after glucose absorption, beta cells secrete insulin. But suppression of lipolysis occurs, proteolysis and glycogenolysis, that occurs. 2 minutes after eating, insulin bursts out. This is normal. But it lasts 15 minutes and a steady release of insulin takes place. This is all normal, right? However, in type 1, all of that is absent due to injured or dead beta cells. So what's the treatment? Acceptable levels of glycosylated hemoglobin, which is HbA1c levels. We'll get to this as well. It's only maintained by exogenous administration of insulin, and of course its synthetic alternatives. And there's an entire section, long note on insulin coming up. So we must monitor daily blood glucose readings with a home glucometer. However, a monitor of 3 months worth of glucose through HbA1c is much, much more important. Type 2 diabetes. Insulin non-dependent. Okay, basically it's more than 90% of diabetics are type 2. It's influenced by factors such as genetic factors, aging, obesity, and insulin resistance, where this is very, very important. Insulin resistance are tissues where glucose is present, right? It needs to be taken into the cells. So for example, if this is your heart has a cell needs glucose, insulin does that for us normally. Insulin sends glucose up the cells and heart functions well. But if insulin is in resistance, so if our tissues, for example, if our heart cells don't like insulin, then insulin will never send glucose up the cells, and glucose will remain in the blood vessels, never reach target tissues. Okay, that's what insulin resistance is. That our target tissues, target organs are resistant to insulin. So insulin is still present. So patients have tissues with non-functional receptors to insulin, where there is active insulin, but it's deemed non-functional. Etiology: lack of sensitivity of target organs to insulin. Beta cells are retained, insulin is produced, however, not enough to compensate for this resistance. Over time, B cells will decline due to atrophy. Right? They're going to feel like not enough insulin is ever going to get produced, so they stop working. The resistance is normally triggered by obesity. Therefore, type 2 diabetes mellitus can be treated by lifestyle changes. The treatment is maintaining a normal blood glucose level, prevention of long-term complications, weight reduction, exercise, dietary modifications. All of these fall under this area. Pharmacologically, of course, we have oral hypoglycemics that we'll talk about in a lot of detail. And then, of course, insulin therapy is always a good option. So what's the difference? We talked about type 1, type 2. Type 1, age of onset, usually childhood or puberty. Type 2, commonly over the age of 35 or 40. Nutritional status at this time of onset: type 1 is commonly undernourished, and type 2 is obese. Type 1, 5 to 10% of diabetics. Type 2, 90 to 95% of diabetics are type 2. Type 1 has a moderate genetic disposition, and type 2 has very strong. Type 1 is moderate, type 2 is very strong genetic predispositions. And defects or deficiency. In type 1, B cells are destroyed, eliminating the production of insulin. In type 2, inability of beta cells to produce enough quantities because insulin resistance and other defects are already present in the target tissues. Okay, awesome, guys. So you guys are very good at staying put. I'm hoping I've kept you awake and not asleep by now. All right, let's move on. This chart here demonstrates the duration of type 2 diabetes mellitus, sufficiency of endogenous, meaning the one that insulin that body produces, and recommended sequence of therapy. So let's take a look at this nice summary here. Normally, there's relative ability to secrete insulin is very high, and no treatment is needed. When it plummets during impaired glucose tolerance test, so basically a test that tells us whether a person is diabetic or not, during that, insulin is half its original relative ability to secrete. That's when diet modifications can help us, such as reducing the amount of sugar that we eat already. Whenever somebody is diagnosed as type 2 and they've only been 0 to 5 years in their experience, then diet with metformin, which is oral hypoglycemics, they can be used. But as soon as a diabetic enters 5 to 15 years, then a combination therapy, which is insulin plus oral hypoglycemics. And lastly, when a diabetic type 2 has been in the case for more than 15 years, then insulin is the best course of treatment. Okay, it's a very good note for you guys to write in the point of a summary, so please do note all of this down, guys. Moving on, the release of insulin that occurs in response to IV glucose in normal patients and diabetic patients. So the blue line is normal, red line is diabetic. In a normal patient, when you give IV glucose, IV glucose, the plasma concentration of insulin is spiked up very, very high. Very high, right? Normal people. But in a diabetic, in type 1, it's very, very less, almost next to nothing. That's because beta cells are dead. No matter how much glucose you give, it's not going to stimulate insulin release. But in type 2 diabetes, there's some. There's some insulin response, some insulin release, but not enough to be appropriate enough to match up to normal patients. So that's the difference in plasma concentrations of insulin once glucose is infused. Now, insulin resistance in peripheral tissues, such as liver, increases production of glucose because insulin's job, what is insulin's job? Okay, let me write that down here so you guys can have it in your notes. Insulin's job, so I'm going to write with the red marker here. Okay, insulin does two things. One, it breaks down glucose. Okay, and then second, it sends glucose. So where does it send it to? Inside cells, away from blood. And that is the important part. In its absence, glucose will increase. Cells will never receive it. It will always remain in the blood. Therefore, the liver increases the production of glucose and decreases glucose uptake by muscles and other adipose tissue, organs. That's insulin resistance, right? Decreases glucose uptake. Therefore, it stays in the blood all along. Second is inadequate insulin secretion from beta cells. Pancreas doesn't produce enough insulin. So hopefully that whole concept is now clear because we're about to dive into insulin and it's a deep, deep topic, so stay with me, you guys. Okay? Naturally, works to reduce blood glucose levels. We got that clear. Hypoglycemic hormone for regulation of blood homeostasis. Great. We're clear on that. In chemistry, however, it is a polypeptide hormone made up of two chains, alpha, beta. As you can see here, we have an A chain and a B chain, okay, connected by disulfide bonds. And that's just the chemistry. Disulfide here, disulfide here, disulfide here, right? It's the simulation of release. How does insulin get released? Well, there's molecules, there's signals, right? Insulin secretagogues, they trigger beta cells to release insulin, and C peptides. 50-50. Now, the fun part here is something's got to target secretagogues, right? Secretagogues are just messengers. They just go to the B cells and be like, hey, can you release insulin? Can you release C peptides, please? What tells secretagogues? That's the question. So, trigger of secretagogues. Here is the mechanism through which secretagogues get stimulated. First of all, increase in blood glucose levels, beta adrenergic activity, and gluconeogenic amino acids like leucine, arginine, glucagon levels, they contribute to the following process. All of that is fancy for saying eating sugar. Fair enough? Awesome. Normally, these are all taxied by glucose transporters, GLUT into beta cells. GLUTs are the transporters, so it's a taxi. It takes sugar from the blood to GLUTs. GLUTs take them to the beta cells. Then, beta cells provide a glucokinase phosphorylate process of glucose. Glucokinase phosphorylates, once that is all done, it turns into a glucose sensor. Okay, we're following so far, the story is good. ATP is made as a byproduct of this metabolism, glucokinase phosphorylates. Adenosine triphosphate is a form of energy that attaches itself to K channels and closes it. Okay, K channels are produced on the cells of the, so this is a beta cell, there's K channel, and it closes it. Now, if the K channels close, then B cell membranes is now depolarized, and in order to bring it back to normal, calcium comes inside. And we know what happens when calcium comes inside. There is increase in intracellular calcium, triggering insulin exostosis. This process is what secretagogues end up doing. If there's a trigger, a stimulation, there's got to be an inhibition. Drugs like diazoxide, phenytoin, colchicine, they prevent this entire process that we just talked about. In metabolism, insulin goes through higher hepatic and renal metabolism. So lots and lots of metabolism of insulin takes place, but C-peptides don't. So essentially, if we want to measure how much insulin there is in the body, we can't really look for insulin levels because they're highly metabolized. You can't tell. So what do? We measure C-peptide levels in order to see how much insulin a person has. Now, why is that? Well, because it's produced 50-50 at the same time through B cells. That's why. So that's the insulin's story. Now let's talk about certain ways that the glucose is triggering the release of insulin. Okay, so here it is. First of all, we have glucose. Glucose is now attached from the blood to the beta cells using GLUT2. So let's draw our attention to GLUT2. Where does it exist? It exists on beta cells of pancreas, liver, kidney, and gut. Glucose volume 15 to 20 millimoles per liter is transported. And what does it really do? It regulates insulin release and other aspects of glucose homeostasis. So GLUT2 all of a sudden is a very important glucose transporter. Glucose goes into beta cells. Firstly, it metabolizes using this process here. Glucokinase phosphorylation. That's what happens here. Glucokinase phosphorylation. ATP is produced as a byproduct. ATP closes the potassium channels and depolarizes the cell. Right? Potassium stays inside. Because of that, calcium channels open and they come inside the cell. Intracellular calcium comes in. Ultimately, insulin is in storage right here. Calcium says, okay, I need you out. Let's go out. And exostosis happens of insulin. Insulin goes to the blood and prevents hyperglycemia. Okay, so now let's draw your attention to this area right here. Do we see how it says sulfonylureas? For first instance, sulfonylureas are oral hypoglycemics. They're first-line drugs. They end up blocking potassium channels as well. Now, they block potassium channels, causing influx of calcium and then insulin release. So what do? They are insulin secretory stimulants. Perfect. That's sulfonylureas. Now, remember GLUT2, don't forget about that. Very, very important point in this process of insulin. Moving on, insulin, once it's in the blood, it carries to various tissues in the body and uptaken by their membranes and special insulin receptors into the tissues and metabolized to produce a range of effects depending on the target tissues. That's what insulin does. The main function is to remove glucose from the blood, prevent actual genesis of glucose. Two main functions: prevent glucose formation, and then of course whatever glucose exists, send them up into tissues, organs, cells, so it stays out of blood. Anabolically, insulin promotes the storage of glucose in the form of glycogen. We went over that earlier. Insulin promotes the synthesis of proteins and glycogens as well. So it actually makes the storage containers. It actually produces protein that glucose is attracted to. Therefore, it promotes the anabolic action of storage of glucose. Insulin also tends to draw glucose from the blood and put it back into the cell, leading to a hypoglycemic feature of insulin. In the lack of all of this, of course, there will be hyperglycemia. And that hyperglycemia, ladies and gentlemen, is known as diabetes mellitus. So the important note here is that insulin can be deficient in production. Tissues can be resistant to insulin. And in both circumstances, hyperglycemia, meaning diabetes mellitus, occurs. The effects of insulin is very vast on different organs. So on liver, it reverses the catabolic features of insulin deficiency. It inhibits glycogenolysis. It inhibits conversion of fatty acids, amino acids to keto acids. It prevents it. Remember that. It prevents it. Inhibits the conversion of amino acids to glucose. In anabolic action, it promotes the glucose storage as glycogen. It induces glucokinase, glycogen synthase, inhibits phosphorylase. In essence, it just puts glucose back into storage. It increases triglyceride synthesis and very low density lipoproteins, so LDL and triglycerides. These are bad proteins, you guys. And of course, they're cholesterol, so it causes heart problems. In muscles, it increases protein synthesis. That's great. It increases amino acid transport, increases ribosomal protein synthesis, increases glycogen synthesis, mobilizes glucose, induces glycogen synthase, and inhibits phosphorylase. Later, on adipose tissues, it increases triglyceride storage. Lipoprotein lipase is induced and activated by insulin to hydrolyze triglycerides from lipoprotein. So triglycerides go up. Glucose transport into cell provides glycerol phosphate to permit esterification of fatty acids supplied by lipoprotein transport. In other words, it breaks down fat. Intracellular lipase is inhibited by insulin. So inside the cell, there is a molecule that tends to metabolize fat tissue. It prevents it. And therefore, it prevents any weight gain. That's insulin's job. Hypoglycemia. Now, this is a really fun short note. Hypoglycemia is the most frequent and a lethal, reaction to insulin excess. Too much of insulin causes hypoglycemia. Insulin is normally a counter mechanism to glucose intake, such as breakfast meal. So whenever you eat breakfast meal, you had cereal. Cereal has a lot of sugar. Sugar sticks to insulin and sends it back into cells. That's the whole sugar process. As soon as we have a breakfast meal, sugar gets readily absorbed and triggers insulin release. Diabetics who lack insulin take medications, and they have several formulations of insulin to do the same job. If a diabetic who took medication of insulin and skipped a meal before coming to a dental treatment, then they can suffer from increased insulin activity and a decreased glucose activity. That, ladies and gentlemen, is known as a dental emergency of hypoglycemia. Perfect. Hopefully that's clear. Moving on to symptoms of hypoglycemia. How do you recognize this dental emergency? Well, counter-regulations of sympathetic systems, which is beta-adrenergic system, is seen. It's aimed to promote gluconeogenesis and glycogenolysis. In other words, lysis of glycogen storage. So it breaks open glucose and it produces gluconeogenesis, new glucose. This is when new glucose is made and glycogen is broken down into glucose to rise the serum glucose levels. Other sympathetic responses include sweating, anxiety, palpitation, tremors, pale face, cold skin. These are symptoms and signs that we can see in a hypoglycemic patient. Neuroglycopenic response includes dizziness, headache, behavior changes such as confusion, irritability, hunger, fatigue, incoordination, hypotension. So basically these are basic symptoms. These are one level up. And of course that leads us to a higher level of symptoms. In severe hypoglycemia, it can show mental confusion, seizures, and loss of consciousness all the way up to coma. In this case, a hypoglycemic reading on a glucometer will read less than 40 milligrams per deciliter. And we'll discuss that in a bit. Remember, milligram per deciliter is how we measure glucose, or one way of measuring glucose. The treatment is oral and IV glucose, of course. Oxygen that is needed because of the neuroglycopenic, and penic basically just means reduction. Glyco is basically the useful glucose, and neuro means brain. So brain is getting less glucose. That's all it means. And of course, we must monitor vitals. So overall summary of all hypoglycemic side effects: tachycardia, confusion, headache, anxiety, vertigo, diaphoresis, which is sweating, shaky tremors, increase in appetite, which is hunger, blurred vision because of retinopathy, remember? Weakness and fatigue because there's lack of sugar in the body, so low energy. Lipodystrophy just at the site of the injection. Dystrophy just means change in shape, and lipo just means adipose tissue, where we induce injections. Just that site, that area has lipodystrophy, and someone can also be hypersensitive to insulin as well. All right, so what are the other effects of insulin? We went over this slightly, but let's retouch it with a little bit of detail. Local reactions include swelling, erythema, stinging at the site of injection, as well as lipodystrophy. Localized lipodystrophy, which is subcutaneous fat deposition at the site of injection as well. That's local. But in allergic reactions, you can see urticaria, angioedema, anaphylaxis. These are rare, but only if the preparation of the insulin is contaminated, only then. And this belongs under the hypersensitivity. And that would be seen here. Now, there are several drug interactions faced by insulin. Obviously, it affects a lot of organ systems. Beta-adrenergic blockers and insulin, they will prolong hypoglycemia. They will make hypoglycemia, so increase insulin's effect. Thiazide, furosemide, these are antihypertensive drugs. Oral contraceptive, salbutamol, this is anti-asthmatic drug. They diminish the insulin sensitivity of organs. Therefore, no matter how much insulin there is, it will never be useful. Alcoholism prolongs hypoglycemia by reducing liver glycogen. Lithium, theophylline, and aspirin. These drugs prolong hypoglycemia by excessive insulin release. They stimulate insulin release, and these are drug interactions. Tissue resistance of insulin, the topic we keep talking about, but let's learn it slightly deeper. Suboptimal tissue response to optimal levels of insulin. That is the entire summary of the whole topic. Metabolic syndromes can also offer tissue resistance to insulin, such as hyperinsulinemia, meaning increase in insulin in the blood in type 2 diabetes can be associated with tissue resistance. Because if there was no resistance and insulin was taken up by tissues, then there wouldn't be hyperinsulinemia. It would just be normal insulinemia. Then there is dyslipidemia, hyperuricemia, and hypotension can also be seen. Sedentary lifestyle, old age, obesity. These are very common features seen that can cause tissue resistance of insulin. Treated insulin preparation administration. So the only way to treat these cases, insulin preparations. So we'll talk about all the drugs that can be offered in that case. Stimulants of insulin release. What stimulates and what inhibits insulin release? Let's take a look at that. Humorally, glucose, mannose, leucine, arginine, amino acids, fatty acids, all in high concentration, they release insulin. Hormonal, glucagon or glucagon-like peptides. Glucose-dependent insulinotropic polypeptide or cholecystokinin and gastrins. These are all hormones that stimulate insulin. Somebody asks you, which hormone stimulates insulin? Then this list must be on top of the list. Okay? And then in the brain, the neural systems, beta-adrenergic stimulation and vagal stimulation causes insulin release. Specifically, beta-2. Don't forget that. Okay, guys, moving on. Drugs. For stimulating insulin release, what do we use pharmacologically? Sulfonylureas, meglitinide, nataglinide, isoproterenol, acetylcholine. Remember, so isoproterenol and acetylcholine are from autonomic nervous system. These are oral hypoglycemics that we will talk about. Inhibitors of insulin release, hormonal, somatostatin. Remember, inhibitor of secretors. Of course, insulin is the inhibitor of insulin release, and leptin. Neurally, alpha sympathomimetic effects of catecholamines. Remember, this was beta-2. However, inhibiting insulin release is the responsibility of alpha. Okay. Drugs like diazoxide, phenytoin, vinblastine, colchicine, they tend to inhibit release of insulin. Perfect. Now, a little short note on blood glucose versus the H1B level. There are two types that we measure, right? We measure at home. And this is measured in either milligrams per deciliter or millimoles per liter. However, HbA1c is percentage. Okay, let's take a look at it. Plasma or serum glucose levels are measured in milligrams per deciliter or millimoles per liter. There's fasting glucose and there's postprandial glucose. Fasting means level of glucose after 8 hours of no food. 8 hours. So basically when you wake up. Postprandial glucose level after 2 hours of just eating. So remember those two, because those two will tell us what type of readings to keep an eye out for. In fasting glucose, less than 126 milligram over deciliter should be good, but more than 126 milligram per deciliter or more than 7 millimoles per liter is considered diabetic. Very, very important point. Please write it down, you guys. Also, a 100 to 125 milligram per deciliter or 5.6 to 6.9 millimole per liter. This is the risk of diabetes. These people are at risk. Therefore, if risk for diabetes is suspected, then the clinician must do glucose tolerance test. How do we perform glucose tolerance test? Well, patient does not eat after midnight. At 8 a.m. in the morning, an adult patient will be given 75 grams of glucose in a 300 milliliter water container. And a child patient will be given 1.7 milligrams per kilograms. Once that's been given, that drink must be completed within 5 minutes, and then blood samples are collected within 2 hours. And then let's see what we find. A normal patient will have a fasting glucose, we learned about it, that it's less than 100 milligram per deciliter, or an actual value of 5.6 millimole per liter. But in a tolerance test, a normal person will show less than 140 milligram per deciliter, or 7.8 millimole per liter. In a diabetic patient, fasting glucose is more than 126 per milligram per deciliter, or 7 millimoles per liter, more than that. And in a tolerance test, in this test right here, a diabetic patient will show more than 200 milligrams per deciliter and more than 11.1 millimole per liter. HbA1c is a little simpler, you guys. So it's measured in percent of hemoglobin. What type of hemoglobin? It's called glycosylated. Results display 3 months because of the RBC's lifespan is 3 months, 120 days. And HbA1c is a form of hemoglobin that anything that this hemoglobin, this red blood cell is seen through, is going to be shown, which is 120 days worth of results. HbA1c, more than 6.5%, person's diabetic. HbA1c less than 5.7, very, very good, normal. Therefore, anyone between 5.7 and 6.4 is at risk of diabetes. How clever. But this cannot be done at home, so we need lab testing for it. So essentially what HbA1c looks like visually is that this is an RBC cell, red blood cell, and of course it has hemoglobin on it. We all know that it carries oxygen. But when glucose glycosylates this hemoglobin, it looks like this. Glycated or glycosylated hemoglobin is known as glycohemoglobin, and that is HbA1c. Perfect? Amazing, guys. You guys are doing great. Okay, so let's put this together in a chart format for better understanding and a good sign and notes. Okay, so we have 3 types, right? We have fasting plasma glucose. We have 2 hours after glucose load, which is a meal, and that is known as postprandial. And then of course HbA1c levels, and this is the main criteria. Fasting plasma glucose measured in 2 types of readings, milligrams per deciliter and millimoles per liter, shows 3 different types of statuses. Either a person is normal, pre-diabetic, or diabetes mellitus. Fasting glucose less than 100 or 5.6 millimoles per liter is normal. 2 hours after meal, milligram per deciliter levels less than 140. Millimoles are 7.8, very normal. HbA1c less than 5.7, very normal. That's great, we cleared that. Fasting plasma glucose in a pre-diabetic at 100 to 125 or 5.6 to 6.9. Now it is important to see here that it says at risk of diabetics. That is the same thing as pre-diabetics. And then of course the postprandial levels, more than or equal to 140 to 199, your risk of diabetes, which is 7.8 to 11.0, risk of diabetes, pre-diabetic. And HbA1c levels between 5.7 and 6.4, pre-diabetic. Diabetes in diagnosis, very, very, very important to know what is diabetes. Fasting plasma glucose, more than or equal to 126 milligrams per deciliter, 7.0 millimoles per liter, or postprandial, more than 200 or equal to 200 milligram per deciliter, or 11.1 millimoles per liter. Lastly, more than 6.5 or equal to 6.5 HbA1c. This is diabetes mellitus. Insulin formulations is classified based on the onset of action, duration of action, They're either rapid acting, short acting, intermediate acting, or long acting. Human insulin is dispensed as just regular insulin, and the neutral protamine H-drawn NPH formulation. So our NPH is just human insulin. Okay, just to keep in mind. There are 6 analogs of this though. Lispro, aspart, glulicine. Lispro, aspart, glulicine. These are rapid acting. Okay, so remember, in this case, lagging is not slow. Lagging is rapid. Lispro, aspart, glulicine. Then there's long-acting ones. Long-actings are glargine, detamere, and deglutec, which are long-acting, which is DDG, LAG, DDG. Okay, awesome. Moving on. North American availability of insulin concentration is at 100 units per milliliter. They're known as U100. It's dispensed as pre-filled pens. We just stick it into subcutaneous tissue. Other concentrations such as U200, U300, U500 available for particular type of insulin from the above 6 mentioned. So these are our insulin formulation Bibles. Okay. Human insulin has a peak action of 2 hours. So basically this R, 2 hours of peak action. Human NPH peak action at 6 to 7 hours after administration. But rapid has a peak action at 1 to 1.5 hours after administration. A long insulin has no peak action at all. So that you can tell that duration of action and onset of action is very, very relevant in formation of insulin. So let's take a look at the summary chart we created for you. Human regular insulin, which is R, onset is between 30 to 60 minutes after administration. Duration, 6 to 8 hours. NPH, which is neutral protamine H-drawn, 2 to 4 hours after administration is the onset, and 10 to 20 hours it will last in duration. Again, remember, these are peak actions here. Lispro, aspart, glulicine, which is rapid. Remember, the lags are rapid. Onset of action, 5 to 15 minutes. That's rapid. And duration of action, only 3 to 4 hours. So duration of action is reduced because it's rapid. Glargine, detamere, and deglutec. These are DDG. DDG is long acting. That is 30 to 60 minutes it takes for the onset, but it lasts 17 to 42 hours, you guys. Therefore, it's long acting. Hopefully this insulin formulations window is clear. I'll erase it so you guys can pause and write these down because these are very, very important. This chart here tells us the concentrations available for short-acting, long-acting, and pre-mixed. Now, pre-mixed is necessary because sometimes a person needs a part of regular and NPH. Sometimes people need a basic long-acting and a short-acting at the same time in concentration of 70, 70, 30, 50, 50, 75, 25, and so on. And remember, all of these are 100 in concentration. So here's a chart to show us exactly what we just talked about. So if you think about it, I'll change the color here. Insulin aspart, insulin lispro, and glulicin. This is rapid. Purple is rapid. See how it peaks instantly, but then it diminishes effect very, very quick at around 4 hours. These are in hours, and these are plasma levels. Regular insulin peaks very, very nicely and then slowly deteriorates in about 8 hours. NPH insulin, it slowly progresses, never reaches that height, but it lasts longer, up to 18 hours on this chart. Insulin detamere and glargine They are long actings and they last longer, but they never reach that high. You'd notice their peaks are very, very small. But they last much longer, up to 20 hours here as well. And this is just keeps going up to 24 hours and even longer. Perfect. So moving on to the next section here. Insulin formulation has combinations. We kind of touched up on it earlier, such as 70% NPH with 30% regular, 50% NPH with 50% regular. These are available in the market. Various combinations work in the favor of the patient as they have to reduce the number of injections. So for example, if you took a rapid, then your meal is covered, perfect. But if you adjoin it with a long acting, then your day is covered as well. Perfect. Now, some other two little topics I want to talk about here, and these are very important because they are also secreted by pancreas as well, such as amylin. But a synthetic version of amylin is basically amylin's a hormone, right? It's secreted by B cells. The function, though, is to reduce the appetite by delaying gastric emptying. So it reduces postprandial glucagon secretion. So essentially what's happening is that you eat sugar. Sugar needs to go to intestine in order to get absorbed, and then it gets into the blood. But if I delay this action right here, then no intestine, no absorption, and no sugar in the blood. Therefore, it reduces postprandial glucagon secretion. Glucagon is the promoter of glucose uptake into tissues. The drug is pramlintide. It is administered subcutaneously prior to meals. But remember, we must adjust the insulin levels because reduced mealtime insulin to 50% is needed when you're taking amylin. Otherwise, the adverse effects will be hypoglycemia, where insulin's also working, amylin's also working, right? Nausea, vomiting, and anorexia can also occur. On the other hand, incretin. Incretin is a hormone responsible for 60 to 70% of postprandial insulin release. Example, glucagon-like peptide, GLP. Glucagon-like peptides, they stimulate postprandial insulin. Right? As soon as glucagon is secreted, their peptides tend to stimulate insulin release as well. What are the drugs though? Because we're incretin mimetics. The drugs are exenatide and liraglutide. The functions are they act as GLP-1 agonist and improves the insulin secretion and reduces the appetite by reducing gastric emptying. Postprandial glucagon is also reduced and beta cell proliferates as it is induced. Therefore, hyperglycemia is reduced. I hope these stories, these chain of thoughts are now clear, you guys, and it's helping you visualize what's happening. Because amylin and incretin is not something we normally talk about in diabetes, but they exist. Adverse effects, nausea, vomiting, diarrhea, constipation, but also pancreatitis. Because in this incretin mimetic classification, there is beta cells proliferation in the pancreas itself. Awesome. Thanks for staying up with me, you guys. You guys are doing great. This chart over here shows that if we administered insulin in different formulations, what would happen? So let's take a look at this. In the morning, afternoon, evening, night, and all throughout the same. This is breakfast, lunch, and supper, and bedtime. If we give regular injection at breakfast, regular at lunch, and regular at supper, then perfect. Insulin effects is very stabilized, your meals are controlled, and you give bedtime NPH, which means it kind of lasts you all throughout the night, and right when you wake up, you do your breakfast again. Great, that's perfect, right? This one here is a pre-mixed insulin combo. It is NPH regular 70 to 30. Do you see how it reduced 4 injections down to 2 injections? That's because during breakfast, you took an injection with regular, which is great. You took also NPH, which kind of lasts you almost at the beginning of the supper, so the whole day. Supper, you took one, regular, and then the NPH kicks in again as well, and it stays with us all night, and we don't have to take any other injections after. This one here is Lispro, which is rapid, but it needs to be clubbed with a long-acting. Otherwise, rapid-acting will fade away really, really fast. So we take breakfast, lunch, and supper, rapid action. And then at bedtime, we would take our long-acting, like Glargine, and it lasts us all day until the end of the day. Perfect? Awesome. Now, standard insulin versus intensive insulin. Now we're talking about therapies, right? We made our way from single insulin to rapid to long to all of the sudden in combinations and so on. So now we're into actual therapies. Standard insulin therapy, you got to go twice per day injection. Very useful. Intensive insulin therapy is 3 or more per day injections with blood glucose monitoring. The target blood glucose for a diabetic patient would be 154 milligram per deciliter or less than 7 HbA1c. But for a normal patient, blood glucose will be less than 115 milligrams per deciliter and less than 5.7 HbA1c. So remember these two differences, very important during insulin therapy. Intensive insulin therapy achieves this target with more accuracy. Therefore, it's better to do intensive. So what are the negatives of intensive insulin therapy? There's a higher frequency of hypoglycemia, coma, and seizure because we're giving 3 and more injections per day to cause hypoglycemia. So imagine, there's more probability. That's all that means. But the positives of intensive insulin therapy are that there's lower microvascular complications such as retinopathy, neuropathy, nephropathy, and so on. There's less chances of that happening because we maintain blood sugar levels at target with more accuracy. So here's a diagram from our references. Intensive therapy results in a 3-fold increase in frequency of hypoglycemia. This is standard therapy. There's more chances. How much? 3 times. Many clinicians believe that increased risk of hypoglycemia that accompanies intensive therapy is justified. Why? By substantial decrease in incidence of long-term complications of diabetic retinopathy and nephropathy. So there is risk, but they outweigh the benefits of intensive insulin therapy. Okay? Oral hypoglycemics, full note. So you guys can take a break here as this is the second half of the lecture where it's oral hypoglycemics full lecture. This is a classification of oral anti-diabetic drugs from 2 different classifications, from 2 different references. But essentially it's the same. So if you think of it this way, that something that enhances insulin secretion, so it increases insulin itself, they have to do with potassium channels. So remember, if we go back to this section here where we had potassium channels, the reason why insulin is released is because potassium channels are closed, and because potassium channels are closed, calcium moves in and releases insulin. Okay? Now, because of that, when we want to induce the release of insulin, then we need to be able to block this potassium channel. Once they're blocked, calcium moves in, insulin gets out. These are sulfonylureas and meglitinides. Sulfonylureas are usually amides, zide, ride. Very easy to spot, right? Tolbutamide and glipizide will be talked about in detail. Meglitinides are repaglinide, NEET, glinide or nateglinide, for example. These are glinides, meglitinides, glinides. Okay, easy to remember. Now there's another section here, which is DPP4. What their function is, we'll talk about. We haven't touched up on this yet. But these are gliptins. Sitagliptin, vildagliptin, saxagliptin. Saxa is the most notorious of them all. So we'll talk about that. And then lastly, overcome insulin resistance. So this now is associated with tissue receptors, biguanides, and thiazolidinediones. Okay. Now, of course, we haven't talked about these, so we'll talk about the mechanism of actions in just a few moments. This is biguanides, metformin, the first line treatment in oral hypoglycemics. Then these ones, the TZDs, these are glitazones, pioglitazone, rosiglitazone, and so on. And of course, lastly, it's alpha glucosidase inhibitor. Now, the next few slides I'll just show you guys are 1, 2, 3, 4, 5, and 6, 7. These guys are basically our drug classifications. So it might feel a little dry, but here we go. Sulfonylureas, general information. Type 2 diabetes treatment, perfect. Patients for whom diet does not control it. Okay. Patients over the age of 40 years of age with less than 5 years of diabetic episode. Less than 5 years of diabetes mellitus, 40 years and above. Okay. Long-standing diabetics, oral hypoglycemics with insulin combination is very important. Now, insulin secretagogues are those that they promote insulin release from beta cells, and that's what sulfonylurea is. It's an insulin secretagogue. Second generation, presently, it is glyburide, glipizide, and glimepiride. These are the drugs we want to remember in sulfonylureas. Mechanism of action, it blocks the ATP-sensitive potassium channels. Once that's done, causes depolarization, leading calcium to come into play. When calcium comes into play, insulin is stimulated to be released in exocytosis, and it reduces hepatic glucose production. Right? Insulin goes out and says, stop glucose production, please. And it increases insulin, peripheral insulin sensitivity in target tissue as well. A little bit, but it's still there. Moving on, pharmacokinetics. Oral administration, it binds to plasma proteins such as albumin, which means as soon as something is bound to albumin, it is inactive. What does that mean? Well, it catches the train, and that train takes it, so insulin is sitting on this albumin train, and it takes it from point A to point B. In this journey, insulin is inactive, but as soon as it gets off at station A or station B, it becomes active. So it increases the duration of action. Okay, it is metabolized by the liver, and it's excreted in the urine and feces, and duration of action is 12 to 24 hours because of this reason. Adverse effects, there's weight gain, hyperinsulinemia, because albumin bound, it sticks into point A to point B, that journey in the blood longer, hyperinsulinemia, and of course hypoglycemia because it acts longer. Adverse effects also have hepatic and renal insufficiency causing retention of glyburide, leading to hypoglycemia even more, while the other two are safe to use. So remember, glyburide, bad drug, glipizide, good drug, glimepiride, good drug. But it's because it metabolizes in the liver and is excreted in the urine and feces. That's why we need to be cautious. Several drug interactions are noted, such as these decrease and increase are basically drugs that reduce the effect of sulfonylureas, leading to loss of glucose control. And the green ones are drugs that increase the effect of sulfonylureas, leading to even further hypoglycemia. The reason why this happens is because of liver metabolism, right? If the enzyme CYP450 or 3A4, if these liver enzymes can break down glucose or break down sulfonylureas, then other drugs such as atypical antipsychotics, corticosteroids, diuretics, niacin, which is vitamin B3, phenothiazines, and sympathomimetics, which is adrenergic. All of these can also be metabolized by these enzymes in the liver, and therefore it quickly metabolizes sulfonylureas. Therefore, it makes it useless. Therefore, it decreases the effect. But drugs that increase the effect, which means they reduce the metabolizing of sulfonylureas and cause hypoglycemia because it's still active, right? Are azole antifungals, beta blockers, which are anti-adrenergic, chloramphenicol, clarithromycin. Mycins are very bad. Monoamine oxidase inhibitors, the MAOs. And of course, all of this, guys, is in detailed discussion in our general pharmacology lectures, adrenergic, cholinergic, and so on. So please do and go visit and take a look at those lectures as well. Probenecid, salicylates, which is aspirin, and sulfonamides, which is different from sulfonylureas. Okay, it's an antibiotic. Now, we just need to know that these drugs, so I'll erase it just so we know it's better. These drugs, they increase sulfonylurea action because they reduce metabolism, breakdown. And these drugs decrease sulfonylurea action because they increase metabolism. Okay, perfect. Second class, glinides. Glinides generally, in drug classification, they are repaglinide and nateglinide. I know it says NEET, but it's actually pronounced nateglinide. Also considered insulin secretagogues, which means the mechanism of action is the same as ones mentioned here. The potassium channel story. It's used, although in postprandial glucose regulation, guys. So in mechanism of action, it stimulates insulin secretion as well, just like sulfonylureas. It binds to a site, this is site, guys, site on beta cells and closes potassium channel. Okay, calcium influx comes in turn stimulates insulin release. Everything's great, but in contrast to sulfonylureas, these drugs have a faster onset, shorter duration. That's more important. So essentially, sulfonylureas lasted us 12 to 24 hours. But these drugs will not last 12 to 24 hours. They'll be gone easy. Therefore, it is used in early release of insulin right after a meal. So it is used for a very specific target, which is postprandial glucose regulation right after a meal. And pharmacokinetics says that it's taken orally prior to a meal, metabolized in the liver by the CYP450 and 3A4 family, excreted through bile, so nothing to do with kidneys, right? What's the adverse effects? Not used along with sulfonylureas because they will be hypoglycemia. They do the same thing, right? Safer than sulfonylureas, but still can cause weight gain and hypoglycemia. Drugs inhibiting 3A4, which is azoles and mycins, they lead to extended effects. Drugs inducing 3A4, such as barbs, rifampin, carbamazepine, they lead to diminished effects. So very, very simple concept of enzyme induction, enzyme inhibition. And this is explained in our pharmacology lectures ahead in general pharmacology. Use cautiously in hepatic impairment because metabolized in the liver primarily. Okay. Biguanides, very, very commonly known drug, metformin. It's an insulin sensitizer, guys. Now it's not secretagogues, it's just a sensitizer. It increases the uptake of glucose by target tissues. Decreases insulin resistance of target tissues. This is the function. Very important point, guys. It does not stimulate insulin release at all. The risk of hypoglycemia is less because it doesn't stimulate insulin. It just says, glucose, please get used up. It's less due to no risk of hyperinsulinemia. Initial drug of choice for type 2 diabetes is metformin, guys. Mechanism of action: reduces hepatic gluconeogenesis, meaning excess sugar production is stopped. Excess, not normal, excess sugar. It slows intestinal glucose absorption. Therefore, less excess goes into bloodstream. Improves peripheral absorption. Basically, peripheral means target tissues. Absorption of glucose. It keeps glucose out of the bloodstreams, essentially, causing loss of appetite that leads to weight loss as well. Little known fact, metformin is a treatment for obesity. It's also used in PCOD, polycystic ovarian disorder, and it aids in conception. Therefore, it results in ovulation. It can cause pregnancy as well. Pharmacokinetics: orally, well absorbed, has nothing to do with plasma proteins, which is great, and it's not metabolized in the liver at all. Direct excretion through urine. How exciting is that? Doesn't that look like it's a perfect drug for diabetes? Like biguanides, metformin is like #1, right? But here's the adverse effects. It's contraindicated in renal impaired patients because it causes lactic acidosis. Remember that terminology? A side effect of biguanide metformin is lactic acidosis. It must be discontinued in MI patients, which is myocardial infarction, sepsis patient, and heart failure patients for the same reason, because lactic acidosis can lead to further deterioration of the cardiovascular system. Caution: age above 80, patients with heart failure and alcohol abuse, we need to be careful. Long-term use interferes with vitamin B12 absorption. Now, these are major side effects. But again, remember the risk-benefit ratio. We need to think about that as well. Next is thiazolidinediones, also known as TZDs. Generally, TZDs are also insulin sensitizers. So far we talked about 2 insulin secretors and 2 insulin sensitizers. The drug here is glitazones, pioglitazone, rosiglitazone, and does not promote insulin release. Important. No risk of hyperinsulinemia. And then, of course, it's a second or third line treatment, since we already talked about metformin, the big gun there, but it treats type 2 diabetes mellitus. Now, mechanism: increases insulin sensitivity, specifically in the liver, adipose tissue, and skeletal muscles by activating a very specific genetic component, you guys. Transcription of insulin responsive gene. Now, insulin receptor genes, responsive genes, are those genes that respond to insulin upgrade, right? So these genes are normally stimulated by an enzyme, which is an activator enzyme known as peroxisome proliferator activated receptor gamma. Now, why is this so important? Why are we talking about PPAR gamma? Well, because this is a nuclear hormone receptor. It's a stimulator. It's an enzyme stimulator that tells our cells that please become responsive to insulin. Okay? PPAR is a increased insulin responsive stimulator. So rosiglitazone, it increases LDL and increases triglyceride and increases HDL. Bad lipids, good lipids, and triglycerides are all increased by rosiglitazone. But pioglitazone decreases triglycerides and increases HDL. So this is better. The good cholesterol is increased and the bad components of cholesterol are decreased. So pioglitazone is better than rosiglitazones. They're orally administered, they bind to plasma proteins extensively, which means they'll have a higher duration of action. Liver metabolism by CYP450. Pioglitazone is excreted mainly in bile and feces, not in the urine. Rosiglitazone is excreted in the urine. Avoid in nursing mothers. Adverse effects: weight gain due to increase in subcutaneous fat and fluid retention. It can worsen existing heart failure, fluid retention. Avoid in severe congestive heart failure, fluid retention. Osteopenia and fracture risks also present along with liver toxicity. Pioglitazone has an increased risk of bladder cancer. It's just a research found, guys. Rosiglitazone increases risk of cardiovascular diseases because of fluid retention, such as myocardial infarction and death caused by heart attack. Okay, next classification, alpha-glucosidase inhibitor. Generally, acarbose and mannitol are used in the treatment of diabetes mellitus type 2 from this classification. What are we doing? We are stopping alpha-glucosidase. Well, then what does alpha-glucosidase do? Alpha-glucosidase breaks down carbohydrates into glucose from the intestine. So it's a digestive enzyme. Their inhibition is reversible. Right? This inhibition of acarbose and mannitol is reversible. It delays the digestion essentially of carbohydrates when it's taken prior to a meal. It reduces postprandial glucose levels. It's like a story, right? Step by step. Insulin is not in the equation at all. It's in the class of hypoglycemics. They do not cause hypoglycemia. Right? And because there's no insulin, nothing to do with insulin. It's just prevention of glucose absorption, breakdown of carbohydrates. Alternatively, sucrase is also inhibited. Therefore, here's the twist. If this class is used with insulin in a combo, then insulin will cause hypoglycemia. In that case, glucose must be used to revive that hypoglycemia, not sucrose, because sucrose will not be absorbed because sucrase is inhibited. Okay, that's just a little side story. Pharmacokinetics: acarbose is poorly absorbed, metabolized by intestinal bacteria, and excreted into urine. So less effects. Mannitol is well absorbed, no systemic effects. Then it's excreted by the kidneys. Adverse effects: flatulence, that's passing gas, diarrhea, abdominal cramping, GI effects, right? Because this enzyme right here is working in the intestines. IBS, which is irritable bowel syndrome, and colon ulcerations are conditions that these drugs should be avoided in. Next classification is dipeptidyl peptidase 4 inhibitor, DPP inhibitor. Generally, these drugs are allogliptin, linagliptin, so all the gliptins, and saxagliptin and sitagliptins. They're used in the treatment of type 2 diabetes mellitus. The mechanism of action is inhibition of, obviously, the enzyme, DPP4. DPP4 is responsible, normally, for inactivation of incretin hormone, such as glucagon-like polypeptide, number 1. If DPP4 is inhibited, then incretin prolong their effects by releasing more insulin in response to the meals. So we talked about this enzyme earlier. And of course, reduction of glucagon release is noted as well. So essentially, lack of glucose in the bloodstream. That's the goal. Pharmacokinetics: well absorbed orally, Allogliptin, sitagliptin, both are excreted through urine unchanged. However, saxagliptin is metabolized by liver enzymes CYP450 and 3A4, producing active metabolites, which means increases in duration of action. It's excreted to kidneys. Nasopharyngitis and headaches are common side effects of DPP4 inhibitors. Infrequent pancreatitis is seen. Strong drug interaction with CYP453A4 metabolized for saxagliptin. Remember, it was notorious. Ritonavir, itraconazole, clarithromycin. So all antimicrobials that are metabolized by CYP450 and 3A4 affect the duration of action of saxagliptin. And lastly, sodium glucose co-transporter inhibitor. Now, this is another enzyme, another molecule, another signal. What does it do? Let's find out. Generally, the drugs such as the flozins or liflozins, canagliflozins, dapagliflozins, these are used in the treatment of type 2 diabetes mellitus from this classification. So mechanism of action is the sodium glucose co-transporter, which is the SGLT2. Normally, it's responsible for reabsorbing all the filtered glucose from the kidneys back into the bloodstream. Inhibition of this co-transporter leads to the decreased absorption of glucose from the kidneys, increases urinary excretion of glucose. Perfect. Therefore, it decreases glucose in the bloodstream. It can reduce systolic blood pressure as sodium follows reabsorption. Now, if you think about it, the sodium glucose co-transporter not only takes glucose back to the blood, it also takes sodium. Okay? Sodium takes water with it. Water follows sodium. When that happens, there is increase in blood volume. Because there's increase in blood volume, there's increase in cardiac output. Therefore, there's increase in blood pressure, right? But the inhibitor prevents all of that. Therefore, this class of drug can reduce systolic blood pressure, but not indicated in hypertension treatments at all. This is just an effect that it causes. Pharmacokinetics, administered orally once each morning, once only. The canagliflozin takes before first meal of the day, so right in the morning. It's metabolized into inactivated metabolites by the liver's first pass metabolism. And then 2/3 of its elimination is into feces and 1/3 elimination from kidneys. Avoid these drugs in renal impairment patients. Adverse effects. It causes a vulvovaginal candidiasis, which is female genital mycotic infection. That's a fungal infection or a bacterial UTI. Because it works in the kidneys, right? It has a lot to do with the kidneys. Hypotension, which is this action right here. Hypotension can occur in patients who are already on diuretics and are of old age. Okay. So overall summary, visual summary of side effects of hypoglycemics. The glinides and sulfonylureas cause hypoglycemia because they are insulin secretors. Biguanides and alpha glucosidase inhibitors, they affect GI. Remember, biguanides is metformin. Metformin causes weight loss because it reduces appetite. Alpha glucosidase inhibitor affects the enzymes on the lining of the intestine. And that causes stomach issues, GI issues. Sulfonylureas, glinides, and TZDs cause weight gain. Biguanide metformin causes nausea. And DPP4 inhibitors causes pancreatitis because it increases B cell proliferation. Okay, moving on. This is the type 2 diabetes mellitus treatment protocol. This is for you guys to note down, but we'll just essentially go over this chart here. That a patient with type 2 diabetes, which is when HbA1c levels are more than 7, you start with metformin. And remember, it is less than 5 years of diabetic experience and more than 35 to 40 years of age. Okay, so titrate to maximum dose tolerable for 3 months. Then if the HbA1c is less than 7, then continue metformin, diet and lifestyle changes. But if it's not less than 7, if the HbA1c is not controlled, then add another oral agent such as incretin or insulin for 3 more months. Check if the HbA1c is less than 7. If yes, then continue the therapy that's been given, diet and lifestyle. But if no, if the HbA1c is still more than 7, after 3 months of that, add another oral agent, so one of the two again. And then we wait 3 to 6 months. Is HbA1c less than 7? Yes, continue that therapy. If no, then multiple daily doses of insulin and basal bolus is given. Okay? So essentially that's how we proceed. It takes up from 9 to 12 months for a proper regime to be formed for diabetes treatment. Metformin is preferred unless contraindication, so it's first line. Goal of HbA1c is usually less than 7. So diabetic patient, we want less than 7, but should be individualized because some people's less than 7 can also equal hypoglycemia. So their target becomes less than 7.4 or less than 8.1, depending on individualized. But overall, 7 is key. A higher HbA1c is more likely due to need of insulin. So multiple insulin injections, okay? This presents the same in a shorter format. This is another diabetes, type 2 diabetes mellitus protocol. Similar, is just for your notes. I would stick to this format right here. It is the most clarified format, but you can pause here and take notes as well. Now lastly, as promised, there was acute complications of diabetes, guys. So hypoglycemia, diabetic coma, ketoacidosis, and then hyperosmolar hyperglycemic syndrome. These three are acute complications of diabetes. What is hypoglycemia? We know, most common complication of insulin therapy. Increases both autonomic nervous systems, causes tachycardia, palpitations, hunger, nausea, and much more. Dangerous hypoglycemia with convulsions and coma is known as hypoglycemic unawareness. Glucose administration will reverse the hypoglycemia. In a conscious patient, we want to give dextrose and glucose pills. In an unconscious patient, you want to administer 1 milligram of glucose via IM or SC. In diabetic coma and ketoacidosis, DKA is life-threatening complication caused due to absence of insulin in type 1 only. Poor compliance and the use of insulin pump is attributed to DKA incidence. Nausea, vomiting, abdominal pain, very common, right? But very peculiar are deep, slow, cosomal breathing. Coma can be seen with elevated kidney stones, reduced blood pressure, blood pH, not pressure, pH, guys, due to acidosis. Treat with aggressive intravenous hydration and insulin therapy. Okay. Hyperosmolar hyperglycemic syndrome, it's literally the same thing with one little change. HHS is associated with type 2 diabetes mellitus by profound levels of hypoglycemia, dehydration, especially in elderly patients. Drugs such as phenytoin, steroids, diuretics, calcium channel blockers are associated with it. All of the diabetic coma, ketoacidosis, they're all present except for the blood pH levels. They're normal. They're not lowered like in DKA cases where they're acidic because of acidosis. HHS is not acidic. Therefore, all you gotta do is treat it aggressively with rehydration and glucose intervention. These are chronic complications of diabetes. Macrovascular, microvascular. We're already aware of the microvascular from earlier slides. We have nephropathy, retinopathy, glaucoma, and cataract or ocular disease, and neuropathy, which is both. Autonomic and peripheral nervous system defects both are present. Macrovascularly, there's atherosclerosis of large vessels that causes myocardial infarction, ischemic heart disease. There's gangrene, diabetic foot, delayed healing of wounds, and of course, hypertension. This is a more detailed presentation of the same from our references. And this slide, as always, is a summary of all oral hypoglycemics. And it just gives you a basic summary of all that I've been speaking of in a tabular format. So you can pause here and take down all the notes as well. This is reference number 1 and this is reference number 2. Hence, these are our references, guys. So thank you so much for watching, and we'll continue to serve you guys better. Please like, share, and subscribe. It really helps us grow. And thank you for all the subscribers you've given us. Have a very wonderful day and take care.